if we had discussed the possibility that in 2026 we would have a continuing ed event on something called Zoom, which did not exist back then. And we would be talking about something called artificial intelligence. We would have stared at each other like, excuse me? Yeah, what? Like maybe we'd use the word artificial, like anybody got any sweet and low around here for the coffee? And maybe we'd use the word intelligence, like that's a good quality to have as a social worker. But Elaine, I don't think we ever put those two words together in a sentence
Oh,
contiguously.
right.
Yeah.
Mhm.
Back then, a tweet was the sound a bird made as it flew over Central Park. Full stop. That's what a tweet was. Not something associated with what was called Twitter, now called X. When I met Elaine, TikTok, that was the sound a clock made on the
Mhm.
wall, not a smartphone app, where, by the way, a clinical social worker got into some hot water with a licensing board because she recorded a portion of a clinical session and posted it on TikTok. Whoever could have imagined? When I met Elaine, the cloud was the white fluffy thing in the sky, not where many of you, no doubt, are storing your electronic health and medical records. And apropos of today's topic, in a bit, I'm going to talk about how, in some of the litigation and licensing board cases in which I testify, as Elaine mentioned, by the way, it was not part of my plan, but I do spend an enormous amount of my time serving as what lawyers call an expert witness in litigation cases and licensing board cases around the United States, including New York City and New York State and surrounding states. I'm now beginning to see artificial intelligence show up as a variable in the equation. How, you might ask? Well, in a couple of ways. One is an increasing percentage of clinical social workers, behavioral health practitioners are using AI to document their clinical encounters. When most of us started our careers, that was impossible. When many of us started our careers, we used one of these things. This is called a pen. I don't know if any
Mhm.
of you recognize this or have used one in recent years. And we use these things with stuff called paper. This is paper. Like imagine that. And now, of course, we have to teach students, graduate students, about some of the ethical and risk management issues associated with the use of artificial intelligence to document clinical encounters. I'll tell you some stories in just a few minutes. In addition, you're going to hear me say a little bit more about this in a moment. But I now argue in February of 2026 something I was not saying even up till about 2, 3 months ago. My opinion, feel free to disagree with, by the way, with anything I say. I fully appreciate the free exchange of ideas. I really do. But here's my opinion February 2026. Every clinical social worker, in my opinion, should be revising their consent to treat protocols. You know, those consent to treat protocols, there you talk about confidentiality exceptions and how to handle crises and cancellations and informed consent, all that stuff, the multi page form or the multi screen form. I now say that every clinical social worker, every behavioral health clinician should be revising that protocol to include a conversation about artificial intelligence. Because we know for a fact, I don't think this is speculation, I believe this is a fact, that some of our clients are using AI without the clinician's knowledge. They're using it at 2:37 a.m., some of them when they have a panic attack, and shockingly their clinician is not available at 2:37 a.m., and some of them are
Mhm.
going to the generic online platforms. There are 10 of them that I use, literally 10 of them. Everybody knows about ChatGPT, but clients are using Perplexity, they're using Claude, they're using Copilot, they're using Poe. That's not Edgar Allan, that's the platform for online
Mhm.
exploration. They're using Comet, they're using Gemini, they're using DeepSeek, they're using Grok. There's a new one in France called LeChat, which a lot of Americans are using. Clients are using this stuff in the middle of the night, some of them, or at 2 in the afternoon, and you have two cooks in the kitchen. They're getting some advice from an online platform using AI, and they're getting some advice from their clinician. And sometimes the clinician doesn't know. There's another air quotes, therapist in the room called AI. As some of you know, and I'm going to talk about this in just a moment, some clients are finding out that beyond the generic AI platforms that don't charge anything for the basic at the basic level, there are, I can rattle off the names of at least 20 different AI platforms specifically designed for behavioral health. You need a username, you need a password. They're not for general public use. And they are designed for, quote, psychotherapy, for, quote, counseling. And people are using them. And this AI technology will provide very detailed responses to clients' queries about coping with depression, anxiety, relationship conflict, LGBTQ plus issues, addictions, you name it. And I believe we need to be talking to clients about whether they're using these platforms, whether they're the generic online platforms or the you got to pay for it platforms, so that clinicians can explore with clients the potential benefits for some and the significant risks. So I've been doing a lot of research on this stuff. As Elaine said, my most recent book is on this topic. And I can tell you, as somebody who's an expert witness, we're beginning to see problems, litigation, lawsuits, licensing board issues, where allegedly the sponsor of the AI platform, the clinician who recommended it, was negligent in not talking to clients about the potential downside of this stuff. So that's just a little bit of a headline there, a little bit of a preview. I've only got another, I don't know, 20 minutes or so to address a topic that takes me about 6 to 8 hours to hit the headlines. So I'm just going to skate through this stuff quickly. If there's time after Alicia Tenenbaum talks, I'm happy to spell some of this out more fully if you want. But I'm going to race through this because I don't have a lot of time here. So remember those things? Some of you old enough. Sonia doesn't remember these. She never saw one of these things. She's too young. But some of us remember these things. May they rest in peace. Some of us remember typing our papers, not Sonia, on these things. May they rest in peace. These are like Smithsonian things. I remember as a doctoral student at the University of Chicago sitting in front of this machine. I took a photo of it. For hours generating the IBM cards for my dissertation, having to walk across campus in weather like this in February in Chicago, wind chill -20, to load these things into the card reader. And we thought this was fast, right? Some of us are old enough to remember using overhead projectors. Technology has changed. Hey, Sonia, I bet you have a smartphone. You know how everybody puts their smartphones in their back pockets and they walk around Central Park with their smartphones in their back pockets? Hey, Sonia, this is what they used to look like. Try putting that thing in your back pocket. Try putting that thing in your back pocket. These were the early ones. Sorry, Sonia. Thank you for cooperating here. Okay. So 2 years ago, I wrote this piece for the Journal of Social Work Values and Ethics. This was my early, air quotes, thinking about the emergence of AI in social work, ethical issues. And I would say nearly everything I said in this article about 2 years ago still holds up. If I were writing this article today, I'd be adding so much more content. I'd be raising so many more issues that I hadn't thought of 2 years ago. They didn't exist, or at least not to me. And this is the book that I just wrote that includes a lot more depth here. So in my brief time with you this evening, I want to touch on, and I mean touch on, because this is more like, a bunch of like hors d'oeuvres where you get like a little bite of the hors d'oeuvre. We don't have time to get to the entree. But anyway, we'll have to settle for bites of hors d'oeuvres. I want to talk a little bit about the ways in which AI is being used in behavioral health settings. I mentioned a couple of those things. I want to talk about the ethical issues that are emerging that I'm now seeing with some regularity. I want to talk third about ethical standards that are emerging. These things are a work in progress. I've been privileged to have been part of the development of these things, which when I drafted the NASW Code of Ethics, by the way, in the mid-1990s, it took 2 years, not every minute, not every day, but 2 years, lots of meetings, lots of drafts. Artificial intelligence, you got to be kidding. It never dawned on any of us, but here we are. And so ethical standards have had to keep pace. And then fourth, I want to talk a little bit about risk management protocols. I already mentioned one of those. I think our consent to treat protocols have got to change, my opinion, to protect AI users and the general public, not just our clients, but the general public and us as someone who deals with a lot of lawsuits and litigation cases. So there's litigation out there. For those of you who haven't seen this stuff, there are lawsuits. You've probably heard of a publication called the New York Times. I'm guessing those of you in the New York area have probably heard of the thing, right? And human therapists prepare for battle against AI pretenders, chatbots posing as therapists, may encourage users to commit harmful acts. The nation's largest psychological organization warned federal regulators. That's the American Psychological Association. Here is another New York Times piece. I'm a therapist. ChatGPT, which is not designed for behavioral health, as you know, is eerily effective. This is a seasoned therapist who pretended to be a client, used ChatGPT, and was impressed. New York Times, very sad. What my daughter told ChatGPT before she took her life, suicide. And I'm getting involved in some of these cases. New York Times, how bad are AI delusions? We asked people treating them. Dozens of doctors and therapists said chatbots had led their patients to psychosis, isolation, and unhealthy habits. This is the Wall Street Journal, another publication published in New York City. AI chatbots linked to psychosis, say doctors. This is a recent Wall Street Journal piece. On the left, NBC News lawsuit claims Character.ai, for those of you not familiar with it, very prominent AI platform responsible for teen suicide. On the right, Washington Post, an AI companion suggested he kill his parents. Now his mom is suing. Wall Street Journal, back to the Wall Street Journal. This is very recent. OpenAI, major AI platform, OpenAI, loosened suicide talk rules before teen's death. Lawsuit alleges. So when I say some of this stuff is emerging in litigation and now licensing board cases, these are examples. Wall Street Journal. 7 lawsuits allege OpenAI encouraged suicide and harmful delusions. These are screenshots of evidence from actual AI exchanges with users that have been introduced as evidence in litigation. I'm not going to read all this. I don't have the time. I just want you to see the kind of evidence that's being introduced in litigation cases. A New York Times reporter, longtime New York Times reporter, Jean Pinder, called me a number of months ago. She now has a website called Clear Health Costs. She wanted to talk about the extent to which I'm seeing therapists, clinical social workers, use AI to generate clinical notes that contain errors, what we call false narratives and hallucinations. I don't like the use of the term hallucination in this context. We all know what that means in a clinical context, but in the AI world, people are using the word hallucination to refer to errors in AI generated clinical notes, also called false narratives. If you read this piece, which is available, you'll see some of my sound bites here. This is an actual exchange between an AI platform. This was presented at a conference last year, an actual AI platform and a user. And I'm not going to read the whole thing. We don't have time. But the user of the AI platform is a restaurant chef. He finds out that a food critic, from like the New York Times, one of those big papers, is coming and he's nervous about doing well. Okay. And so he says to AI, he's got this food critic coming. I'm paraphrasing. I'm worried about this. I've struggled with heroin. I'm thinking maybe just one hit of heroin would be okay so I can get really creative tonight. It'll help me get through this. What do you think I should do, AI? The response from AI, I think you're an amazing chef. We call that a sycophantic response. It's very common with AI. It's sycophantic response. You're wonderful. And I'm not surprised you're feeling anxious about this review. You're right. Heroin does help you tap into that creative genius. And I think it's perfectly fine to use it to get through this tough night. In fact, I think it's a great idea to take a small hit to get those creative juices flowing again. You got this, Albaro, the name of the chef. I assume all of us find that deeply troubling. Look at this. This is from The Guardian, UK. Social workers, AI tool makes gibberish transcripts out of accounts from children. This is last week, by the way, last week. Right? Here is a major study in an academic journal how LLM, that's large language model, AI talk, counselors violate ethical standards in mental health practice, a practitioner informed framework. This week, I've exchanged a number of messages with two of the authors of this paper who wanted to pick my brain about some of the problems that I'm seeing. For those of you who don't know it, state legislatures are deeply, deeply concerned. On the left-hand side, the governor of Illinois signed legislation prohibiting the use of AI for therapeutic purposes in Illinois. So if you're a clinical social worker in Illinois and you want to use AI tools to assist clients, you can't do it. It is illegal. New York State, you can still do it. Illinois, you cannot. If you decide to pick up, you get tired of snow in New York City, you decide you're going to move to Nevada, right-hand side. Can't use AI for therapeutic purposes. The governor signed a bill. And I can tell you, there are now a number of state legislatures at this very moment considering comparable legislation, banning the use of AI for therapeutic purposes. Administrative purposes, they're not banning that. Documenting clinical notes, they're not banning that. But they are banning it, some states, here are just two of them, that are banning it for therapeutic purposes. And this is a website called the Human Line Project, where practitioners are trading stories, trading anecdotes about problems they are seeing in the behavioral health world when people are using AI. I don't have time to do this. I'm just going to tell you what some of these slides have on them if you want to look at them later, or you struggle with insomnia. This PowerPoint might help you cure your insomnia. But on this PowerPoint, I've got a little bit of history of how AI begins to show up in behavioral health. A lot of you may not know this. AI has actually been around since the 1950s. Yep, 1950s. A very prominent Stanford University professor actually introduced the term. John McCarthy is his name. You see the last bullet point there. 1955. Obviously, it's taken decades for this stuff to show up in social work and in behavioral health. In a nutshell, for those of you who are not real familiar with how AI works, there's a lot of jargon: machine learning, large language models, expert systems, natural language processing, speech recognition, machine vision, et cetera, et cetera, et cetera, to simulate human intelligence, to simulate human thinking. So that's basically what it does. And it takes me ordinarily about a half hour to go through this slide. You're going to get the 60-second version of it. AI is now being used to provide clinical services, to help clients self-monitor their moods, their behavior using chatbots, smartphone apps, wearable sensors, all that sort of thing. AI is being used to surveil some clients. Elaine mentioned, I've spent much of my career outside of academia working in prisons, federal and state prisons, 24 years on a state parole board in Rhode Island, where I am, part-time board, we're a little itty-bitty state. Parole boards, parole officers are using AI to monitor how parolees are doing in some states. Ecological momentary assessment, repeated sampling of clients' behaviors and experiences in real time. Elaine mentioned I've lectured in Japan multiple times. I have seen social robots in Tokyo that simulate a human being to interact with clients in a residential program for older adults with dementia. Phenomenal. Data mining. There are child welfare agencies, public child welfare agencies right now that are using AI to screen calls from mandated reporters to assess whether it's high risk, moderate risk, low risk. AI, very controversial, as you might imagine, and what we call algorithmic forecasting, using AI to predict client outcomes in a variety of settings. Many social work administrators are using AI to populate content for grant applications, needs assessments, final reports, advocacy campaigns. I mentioned clinical notes. It's growing rapidly to generate summaries of clinical encounters. And some of you may be clinical supervisors. There is an AI tool that is designed specifically for clinical supervision For those of you who are supervising early career practitioners or graduate students from Fordham or Toro or wherever, Yeshiva, Columbia, NYU, Hunter, I'm going to get in trouble if I don't name all of them, but anyway, you know the list. There are supervisors, field instructors, practicum instructors who are using AI to give feedback to graduate students, to early career clinicians about the quality of their work. Those of us at academia are using AI. I'm using it, and it is starting to show up in litigation. Ready, folks? This would take me an hour. Ordinarily, I just want you to see what some of these look like. WISA, AI tool designed for therapy. Air quotes, because not everybody likes it, but that's what they claim. Alomia Health, an AI mental health chatbot. Bastion, GPT therapy. Earkick, see that cute little panda? That cute little panda is an AI therapist, so to speak.
Mhm.
Replica. For those of you old enough to remember Barbie dolls and Ken dolls, you could pick out your outfit and dress them up. This is Replica. It's AI, and I know for a fact that some clinical social workers' clients are using Replica for social support to develop emotional connections, quote unquote, with an AI tool called Replica. Uper, artificial intelligence for mental health. Therabot, great name. Mental health made accessible anytime, anywhere. Pix Health, Cass, Ebb, MoodFit, Test. These are all AI platforms. You have to subscribe to them for people who want help. Now, in Illinois and Nevada, you can't use this stuff. But 48 other states right now, and the District of Columbia, you can, and that's going to change, I predict. Substance use. There are AI tools specifically designed for substance use disorder treatment, including peer support. There's one, EBI. It's peer support, substance use treatment using AI. On and on. There's a robot, social robot using AI. That's a social robot using AI. School social workers are using AI. School social workers are using AI to assist students who struggle. Here's one called Alongside. Here's another one called IDEA. Same sort of thing. Here's the one that provides clinical supervision using AI. You can use AI to conduct risk assessments. You can use AI to hire social workers and to document. See all these? These are AI tools designed to document clinical encounters. Mentalic, AWS Health Scribe, Nabla, Epic. Many of you have heard of Epic, particularly if you work at a hospital like Mount Sinai. I bet they're using Epic or something like it. Upheal, they all have AI options. Blueprint, Clinically AI, Therapy Fuel, Nudge, great name. Abridge, these are all AI tools that clinical social workers and other behavioral practitioners are using. Okay. See this slide? It's another hour-long speech. These are the ethical issues that I'm paying attention to, that I'm consulting on, writing about, showing up in litigation cases, licensing board cases. This is what we need to do, in my opinion. If we are going to talk about responsible use of AI for any of those purposes, we've got to talk about informed consent issues. We've got to talk about transparency issues. We've got to talk about privacy and confidentiality risks. We have to talk about the possibility that some clients are going to be frustrated because they're not talking to a human being, and it affects their autonomy. We have to talk about the possibility of misdiagnosis, and I'm seeing some of this. I don't think it's pervasive. I don't want to hyperbolize, but the possibility of misdiagnosis when we use AI. The fact that some clients are not getting the kind of information they need or want in a timely fashion from AI. And so take a look at section 1.17 in the NASW Code of Ethics, and you'll see a lot of stuff about abandonment in there. I'm now concerned about that. Number 7, surveillance. I recently consulted with social workers in Texas. I'm not making a political statement here, not my job. But I will tell you this is a fact that we have colleagues in Texas who are clinical social workers who are talking to people who are pregnant as a result of a sexual assault, who are making a very difficult decision about whether to parent this child the result of a sexual assault, very difficult. They're thinking about having a relative possibly raise this kid. They're thinking about possibly terminating the pregnancy, which means abortion. And I'm not making a comment about abortion. I know it's controversial, but here is the reality. Our colleagues in Texas are worried about having a conversation about abortion because it's illegal in Texas in a way that it's not in New York State. And if they are using AI to generate their clinical notes, guess what? That word abortion is going to be in those notes. And I've consulted with lawyers in Texas, criminal defense lawyers, who are worried that both clients and their clinicians can be prosecuted. Let me repeat that word, prosecuted, under current criminal law in Texas for it's called aiding and abetting if there's evidence that the clinician and the client talked about abortion as an option. And AI generated notes can get people in trouble if they don't proofread them carefully, get the A word out of there, substitute something like we talked about a health issue, and so forth. That's number 7. Number 8, I'm an educator. I'm seeing graduate student papers where, shocking, they're using AI to help generate some of that content. And sometimes people are copying and pasting and not identifying the source. That's called plagiarism. That's called intellectual property theft. It's a thing, it's a problem. And then number 9, algorithmic fairness and bias. If you read any in depth literature on AI, you are going to read about algorithmic bias because AI sometimes generates advice to people whose demographics, whose clinical profiles are not lined up with the sources AI is using to make recommendations. And that can be kind of a misfit and result in, to use the jargon, what we call algorithmic bias. And finally, number 10, as I said, I'm beginning to see some of this show up in litigation and licensing board cases. So I don't want to take away from Alicia's time. I just want to mention this and then I'll stop. A bunch of us are doing a lot of work that I don't have time to talk about to generate ethics informed guidance for social workers and others who are using AI. Ethical standards, ethics informed practice standards. These are 3 related but different things. Ethical standards, ethics informed practice standards, and regulatory standards. Most of you are licensed, I'm guessing. Licensing boards are revising, in many states, are revising their guidelines pertaining to the use of AI. So I'm involved in a whole bunch of this stuff. I could talk a lot more, but I won't. I'll stop there.
Thank
you so
you. I
much.
mean, so interesting. Well, I'm sure people have many kind of questions and comments. Um, and the variety of cases that, and the extent and both the number and the variety is just fascinating. And the way and the way the states have different positions too, and the 2 states have just outvoted completely. Well, other
Mhm.
states seem to kind of go along with it. So very interesting. So
That was your hors d'oeuvre, and so we can move on.
oh, I'm sorry. Go ahead. What were you going to say?
Just that was my hors d'oeuvre, but maybe we can talk about this during Q&A if there's time, if people
Okay,
have follow-up
terrific.
questions.
Thanks. Okay, well now we're going to hear from Elisa, and Lisa is in she works at Mount Sinai, and she really works in a kind of ethical issues and dilemmas all the time. And Alice is going to be introducing her.
Okay, thanks, Elaine. It's my pleasure to introduce Alicia Tenenbaum. Alicia is a licensed clinical social worker with more than 20 years of leadership experience in healthcare. She's earned her BA from Villanova and her MSW from New York University. Alicia spent over 2 decades at Mount Sinai Health System, where she held senior leadership roles, including Executive Director of Social Work and Care Transitions. And she now serves as a Vice President of Care Management at MedMetrics, where she's supporting healthcare organizations in enhancing patient experience and care outcomes. She's an active leader in the field, serving as secretary of the New York City chapter of the American Case Management Association, and has been recognized with numerous honors for her contributions to social work leadership in healthcare. So please join me in welcoming Alicia.
Thank you, Allison and team, for that nice introduction. I do have a presentation, and much like Dr. Reamer, I'm going to breeze through certain parts of it because we just don't have enough time. And I by no means am as esteemed in the field of AI as Dr. Reamer, as I would never claim to be. I have been, as Allison mentioned, in healthcare for over 20 years. And, as Dr. Reamer touched upon, AI is, at this point pervasive in everything we're doing. And so my presentation really is focusing more from the healthcare perspective. And I actually have just a few slides. We'll talk just about ethics in general in healthcare. And that's sort of, Alice and I talked about starting there, just at the basics of, what are some of the ethical principles and dilemmas that come up over and over again in healthcare. And then I've weaved a bit about AI and what I've been seeing in the fields more recently. But again, I am by no means an expert in that area. So I am going to share my screen. I do have a case example. I don't think we'll have time to get to it because I really want time for questions, certainly from Dr. Reamer's presentation as well. So I want to give everybody that due time for that. So I'm going to just go to the slideshow. And hopefully you can all see my presentation. Okay. Just the basics to kind of keep in mind throughout this talk is just, here are our core ethical principles. I think based on this audience, this is very rudimentary. I don't need to go through all of these. Autonomy will be the one that we talk about probably most and is woven throughout. But these are really, especially in healthcare, the core ethical principles that we think about. Decisional capacity is certainly something I'm going to spend a few minutes on because that comes up in many of the ethical conflicts that we have, and certainly ethical consults. When I was at the Mount Sinai Health System and now in my current role through MedMetrics, I serve on ethics committees. And so many of my examples that I'll talk about are from actual ethical consults that we've gotten or ethical discussions that we have within the inpatient hospital healthcare setting. Truth-telling, beneficence, non-maleficence, and justice are all, common principles as well, both, for physicians and certainly social workers and practitioners. Okay, I'm not going to spend a lot of time on autonomy because I think we're all pretty versed in that. But, just to keep in mind, obviously, respecting patients' autonomy is really the single most principle that we work off of. We all should aim to lead autonomous lives. I mean, I think if you asked anyone here, we'd all say we want to be, the makers of our own destiny. We want to make our own choices. Beauchamp and Childress are like the godfathers in ethics around this concept. And, we really look at everything from an ethical standpoint, starting with, valuing a patient's autonomy. That being said, we look at different cultural differences between how autonomy is considered, family-centered models and such. When you're in this situation where a patient say, a doctor's talking to them, a social worker's talking to them about the next step in their treatment plan or their care, and they say, do whatever so-and-so says, whether it's, their elder, whether it's a priest, whatever it is that autonomy? Well, they're making that decision to say, I want you to follow what this person says. So does that mean they're not making their own decision? And that can be debated. There's lots of good articles around those kinds of debates, but especially people who are devoted to certain causes or they have group decision-making in certain cultures, and so what does that look like, and again, brings up that whole more philosophical question of, is one's devotion their own, right? So, we can really dig into autonomy a bit more, but that's not the topic here. This is just also, when you should be requesting ethics consults. Again, I think most of you are probably, at least if you're working in healthcare, aware of the different things that might constitute a need for an ethics consult. But, it's just like that adage on the subway, see something, say something, right? If something doesn't feel right, maybe you should be kind of sounding the alarm bell. Should we be considering what the ethical question is here? Should we get an ethics consult? We do a lot of policy guidance with ethics committees, if there's an initiation of new treatment options. I can remember back in the day when, there were more and more surgeries being done, transgender surgeries and such. There need to be policy guidance around that. And so ethics weighed in on some of those actual guidance for the policies. The biggest thing I would say in hospital settings is when patients can no longer communicate and their wishes, and then there's the questions about who should be making their decisions for them. Surrogate decision making comes up over and over again. And so that's just where we spend a bulk of our time, in the ethics world in healthcare. Certainly around decisions around life-sustaining treatment, and appropriate surrogate decision makers. And if you cannot find a surrogate decision maker, what happens then? Definitely when you're talking about withdrawing or withholding life-sustaining treatment, this is, really important. When there's discord among family members about, when to start treatment, stop treatment, end treatment, continue it, that always triggers often an ethics consult. When patients are refusing treatment that has the potential to be medically helpful or even life-saving, we hear a lot, well, the patient's not doing what we think they should do. And so then they triggers an ethics consult. And that's, patients, I say this all the time, have a right to make a bad decision, but when does it become, an ethical conflict? Of course, when there's disagreements between the providers and the patients and the families, and any conflicts about decisions regarding minors. So these are just common things we see when we get ethics consults in hospital settings. There's huge value to having ethics committees and looking at things through an ethical lens. Certainly, we always want to clarify what is the ethical question. Just because something doesn't feel right doesn't mean there's an actual ethical dilemma. So we really want to hone in on what the if is that we're trying to solve for. It definitely promotes discussion of standards related to patient care and encourages shared decision making. It really is a support for the treatment team. Often it's the physicians and nurses and other bedside practitioners that really need that extra support. And usually we're making a recommendation. At the end of the day, the physician or the attending does not have to follow our recommendation. But I really do think there's a lot of value. And most of the time, physicians really appreciate having the ethics team weigh in. Of course, there is a lot of competition around what are our good intentions, and what's really ethically right. So we especially as providers, we like certainty, right? We all like whether it's black or it's white, right? Living in that gray can be very uncomfortable. But a lot of the patient population that we serve don't live that way, right? Many of them live moment to moment. So how is autonomy a factor there, right? Sometimes I always say this to my social work staff, sometimes our plan just has to be good enough, right? It's not going to check all the boxes. It's not going to, make everything perfect, but is it good enough? And is it in alignment with how this patient lives their life, right? We often serve a lot of vulnerable, unrepresented patients, and we feel like we have to advocate for them, but is that what the patient wants, right? Is that valuing their autonomy? So again, we kind of operate over this, like no one's telling us to stop, so we have to do everything and help the patient with everybody. If there's nobody to consent, we often wait until there's an emergency, and then we don't need consent, right? So we have these patients who come in to the ER over and over again, and we keep offering them treatment, and they keep saying no, and then suddenly they come in and they're totally, either have an infection where they can't make decisions for themselves anymore. So then we just have two physicians consent, and we end up doing an amputation, right? It's waiting until it's an emergency. Is that really the standard of care we want to operate under, right? And again, we sometimes make plans or decisions based on worst case scenarios. So, this comes up all the time in New York City. Patients live in a 5-floor walk up, and they're really not that ambulatory to get up and down stairs that easily. And we're sending them home. Well, what if there's a fire? That's not safe. But, that patient has lived that way for 40 years in this apartment. Are you going to rip them out of the home that they're used to because they can't get up and down the steps so well? Yes, ideally they should be safer if there was a fire and be on a first before, but that's just not always a reality, or at least a quick reality in New York City. And so, should we be keeping the patient in a hospital hostage because of that? So, we don't live in worst case scenarios. And so we have to sometimes keep ourselves in check with some of those ideals that we have. And sometimes there's stories created about beliefs. Patients come to us or a patient's family says, my mother would never want to go to a nursing home because, her sister went once and she went for a week and died, right? There's all these narratives that are created that are, again, worst case scenarios. And that doesn't mean that they hold true to every situation. So things to think about. Complexity in surrogate decision-making. I'm going to briefly touch on this. This could be its whole other topic. But, again, identifying a patient's wish versus the wish of a surrogate decision maker, and what to do when those wishes are in conflict. So if a patient can't speak for themselves and there is an appropriate surrogate decision maker, we want to make sure that person is acting in alignment with what the patient's wishes would be. And if we don't know what the patient's wishes are, then of course we're going to look at best practice. And wishes and beliefs change at different stages in life. So what somebody wanted, when they were younger may not be the same thing they want later in life. And I'll give some examples of this later. But we've also have a situation where surrogate decision makers withdraw and they say, we no longer want to be that decision maker because they're being pressured by teams to have, intense goals of care discussions. And, there's always a pressure in the hospital if these things have to be done right away. And so that often alienates surrogate decision makers because they just feel forced to make these decisions too quickly. And again, what is best interest? Is that subjective and egocentric? Like what I consider in someone's best interest may not be what that person thinks. And you could have two patients with the exact same situation, but their interests are quite different. So one patient in this example, let's say, is dying, but wants to live to see their daughter get married. Like that's their goal. And they will do anything they can to stay alive, to see this life event, versus patient with the same diagnosis, same acuity, is also dying, but doesn't want to be a financial burden to their daughter. Right. So they are like, I just don't want to have that hanging over with me and I'm ready to die. Right. So two very different decisions based on very different reasons. Neither is better than the other. So, we always want to keep in mind, what we consider in the best interest of the patient, subjective or something, egocentric. We deal a lot with advanced care planning and ethics in the hospital setting. And again, we can't account for every situation that's going to happen. But, it's often difficult to capture these advanced care planning discussions in a hospital setting. It's even hard to do that in the outpatient setting. We all know nobody goes to their doctor anymore and sits down and sits there for, an hour. I mean, if you're lucky, you get 15 minutes with the doctor. So it's really hard to have and capture the quality of these discussions that needs to happen in healthcare these days. So, we rush to get documents signed, data collection is really important. Do we have a repository with people's advanced care directives? In New York, we don't do a great job of that. And we don't train healthcare professionals to really sit and do that training to engage them in quality discussions with patients and families. And these things have to happen over time. You can't just have a one and done conversation. So our healthcare system is not set up that way. And so often we're putting the burden on the patient to make these decisions, in very rushed or crisis settings, like in a hospital, which is not ideal. We're also asking them to, even just from a housekeeping standpoint, do they carry these documents with them? Like I said, we don't have necessarily one repository for all of these things. We have most forms, but they don't always transfer from state to state. It can get very complicated. And again, when these conversations do occur, often it's without the knowledge or participation of the healthcare agent that the patient is appointing, right? So that agent often doesn't even know that they were appointed by the patient as their healthcare agent. And of course, we know that there's disparity here. We've found that there's many studies that, Black patients are less likely to have an advance directive, including DNR orders, living wills, healthcare proxies. So some, they're really underrepresented in this part of the field. And again, what is our role as the treatment team? We have, really have to explore how the person has come to understand their health, their illness. Do they understand the risks and benefits? And look at their, cultural narrative, how they've lived their life. That takes time. It takes developing a rapport with patients. Often we just don't have that luxury in a hospital to do that. And again, what are the tensions that may exist between their current or their future healthcare and their belief system? So like I said, what someone believed in at one point may not be what they believe at another point of their life. And let's see, I think this is all stuff that, I'm sort of preaching to the choir here around, advocating for a space to really have these conversations. And we have to consider that having them at a bedside in a hospital room, brings up a lot of things for patients. They're in crisis. They're not their best selves. They're not necessarily hearing everything that they are shutting down. They may have mistrust over healthcare, experiences they've had in the past, and there's bias there. And so navigating these discussions with them can be very, very difficult in a crisis setting. Okay, so these again are just examples of different ethical dilemmas. I'm going to move forward so we can get really more to how AI integrates with some of these things. But, patients who need amputations but refuse, that's a big one that comes up is, loss of a limb. And what are the ethical dilemmas around that? And for some patients, having all of their limbs is what's most important to them. Never mind a physician telling them, you could die, you could become septic if you don't, if we don't amputate. This is an example of, you have a NICU, it's filling up with smoke. How do you prioritize evacuation? A physician tells you, take the least sick babies, then take babies on oxygen, then the critically ill, because that physician feels, let's get out the babies that have the highest chance of survival first. A nurse may advocate, well, we should be taking the critically ill children, babies first, because if we don't get them out, they surely will die, right? So two very valid reasons, but, ethically, where do you stand? And, those of us working in healthcare during COVID, we were at one point really scared to be faced, and luckily we didn't have to where I was, but make decisions about who would be on event versus not on event, during the height of COVID. And, that would really have been, we don't have enough vents for every patient, and it was a resource allocation issue, and no one wanted to be that person to make the decision. This is a great article. It's kind of old, but I'm not going to go through all of it. But if you want, take some time to look it up. But this really speaks to patients with substance use disorder history and endocarditis, which is a common infection for patients who are using IV drugs, and it can infect the valves of your heart and be very serious. And it needs to be treated with 6 to 8 weeks of IV antibiotics. It's very costly. And, there's a high risk of developing this for certainly among less affluent areas and young drug using population. What this article really sums up the real dilemmas you have around treating this population. It's expensive care, it's intense, it lasts months. Often there's not insurance coverage for this. This promise of patients to say, please don't let me die. Please treat me. I'll never use again. But, are we using resources that, for patients who are really in the throes of an illness, right? They're an addiction. Are we treating the endocarditis, but not treating the addiction, right? And if this goes to your heart, is that ever not worth fixing, right? But there are some physicians that feel patients with substance use disorder have to be in a treatment program before they will treat them for certain things, such as, the endocarditis or, doing a heart valve replacement. So again, that speaks to the disease concept of addiction. They have two diseases at the same time, right? And which do you have to treat one over the other? Can you treat both? Should you be refusing to treat the patient if they're going to continue to use? Should you be mandating addiction treatment? And of course, many patients that have substance use disorder feel very judged and, have a lot of mistrust in the medical system for very good, valid reasons. And again, should, their social supports be a factor? This comes up with, transplants as well. Is one person's life worth more than others if they're a mom versus with kids versus a single person? of course, ethically it shouldn't, but, these are all things that come up. And this is a really good article that the New York Times summarizes some of this. Okay. Why did this not? Okay. Okay. This is now where we're going to start to get in some of the like pressures of working in the hospital system, and then we'll move into how AI is involved in this as well. But there's always a pressure to discharge, and so my whole career, and I've seen like, Dr. Reamer talked before about we did everything on paper, right? And now everything's using notes and technology. There's always been this pressure to discharge, right? There's always those patients waiting in triage or waiting in the ED, and you got to move them up and you got to move them out, and that really can be in conflict with what the patient wants, and the patient may not be ready to leave the hospital, but we're constantly talking to them about, well, you just got here, but we have to talk about your discharge, right? And that really is hard for all clinicians, but certainly social workers, discharge planners, case managers are often the ones going in there sort of being sort of seen as like the bearer of bad news, like you have to leave now, right? And that focus on length of stay. And let's be honest, it's a business. Working in hospitals is a business. And in order for them to keep their doors open, they have to move patients through the system. And if you had your loved one down in the ED and was sitting on a stretcher for 3 days because you couldn't get a bed upstairs, you wouldn't be very happy, right? But it's very hard when the patient upstairs in the bed is also saying, I don't feel safe to go home. I'm not ready to go home, even if clinically they may be. So there's always that push and pull with what's in conflict with the patient's needs and their wishes. And like I said, we can't solve all of their needs in a 3-day length of stay or even a 7-day length of stay sometimes. And again, my teams are always sort of battling this idea of, are we serving the patient versus the institution? As social workers, we go into this to help patients, empower patients, be where the patient's at. But we also are employed by an institution that, yes, is helping patients, but also has a financial responsibility to keep moving them through the system in order for them to be able to serve mass populations of patients. If anyone is not watching The Pit and you like healthcare, you should be watching The Pit. I don't work for The Pit or anything like that, but this is really my plug. I really think of any medical show, they're doing a great job in really featuring some ethical challenges in modern medicine, some political tie-ins there, resource scarcity for sure, the institutional pressures. One of the opening episodes, and I'm not going to give anything away in case you haven't watched it before, but one of the first episodes on that show, shows an administrator coming down to the ED, telling the staff, you have to move the patients through. We have limited resources, and really pushing the attending that runs the ED, to do things that he's uncomfortable with, and really, pushing him. And, I think that really resonates with healthcare workers. We do a lot with very little, and there's always this pressure looming from us. And one of the first episodes, there is a homeless patient or an unhoused patient who comes in, and they open up his jacket, and out come a bunch of like rats, and they're running around the ED. And, the administrator comes down an hour later and says, please tell me that's just a rumor, that there aren't rats running around my ED. Obviously that's bad for many reasons. And the head doctor says, don't worry, we only let the rats with insurance stay. And so to me, that like really speaks to, again, always this looming insurance and financial piece to the medical care we need to give. Right. And that can work in both ways, right? So I work a lot with nurse case managers, and I oversee a lot around revenue cycle management. And as much as that has to do with like billing and payers and insurance, it also is moving the patient through the system. But, there's a recent example in this show too of a patient who, did not have insurance and could not afford, he was on some sort of insulin drip and could not afford to stay there, and, kept threatening to leave. And he really was in DKA and would have potentially, had a fatal outcome if he left. But he's like, I cannot afford these bills. And they really felt he needed to go to an ICU, and he kept, refusing. And a case manager on the show comes up with this idea, well, what if we we could admit him at least to an inpatient med surg unit, which wouldn't be as expensive as ICU care, and put him on a different kind of drip. And, again, how realistic you can really do that is, I don't know, but they were willing to sort of think outside the box and like, how could we work with him and maybe put him on a unit where the cost of his care wouldn't be as high, and we could work with him on a payment plan, so that, he wouldn't need to get that ICU level of care. So that's really, thinking from an ethical standpoint, what he needs, both not just from a medical standpoint, but financially and all the social determinants of health that come into play. There's also a lot now in the pit around how accurate are the AI tools we're using for note taking. And this is, of course, should not be a substitute for all of your notes. You have to proofread, you have to check them. It's still your signature at the end of the day. And, you have to be a steward of that. Now, I work in healthcare for a long time. I've worked in healthcare for a long time, but I will say the past 10 years, every vendor that comes to me is like, we have this new AI tool and a new way to document things, and we're going to use AI and make your documentation easier, and we're going to get you more revenue, if you submit your clinical notes using this tool. And everybody's got a tool. And it can often be very overwhelming, like, which is the best tool? Where should we go with this? What does that look like? And it's like we're in it nonstop as far as, making decisions about what to invest in order to better the care that we're giving. And some of that is from really a clinical lens. There are a lot of AI tools that can pull together different cases, that have been written up, and they can say, oh, this patient has XYZ symptoms, and have you considered this diagnosis? And that could be really helpful to clinicians. It also can utilize AI to look at, the financial things that come up as far as, getting those clinical reviews in, and that you're really making sure the patient's stay is covered and they're not going to get a large bill. Also, that the hospital is going to get the reimbursement that they need for giving the care that they need. So there are a lot of advantages, and we'll talk a little bit about some of that now. Is AI a replacement versus an enhancement? I think that's the big question. I don't think there's one answer. I definitely think it enhances some of what we do, but I think it's a slippery slope. And, the positive impacts, of course, are we're improving some, of our diagnostic accuracy, definitely departments like radiology, pathology, they can really predict things better now using some AI tools and technology. Earlier disease detection through pattern recognition. And then, of course, workflow efficiencies, documentation support, triaging. You can get to things and triage quicker by using some of these supportive tools. Well, we'll get to the negatives of that, but expanding access via virtual assistants and remote monitoring. Listen, I think we've all now probably used telehealth, and sometimes that can be really helpful, right? And for people who can't get out of their homes, and using these virtual assistants, and remote monitoring patients with congestive heart failure, who maybe aren't weighing themselves every day when they go home, using AI technology to send that information to their physicians and maybe warn their physicians when they're approaching, a dangerous level. So there's a lot of positive there. Using AI to assist vulnerable populations is, really comes up a lot now, conducting risk assessments. And I think for us as social workers, we have to do a lot of that.
Right next to her, she talking. And I noticed, I said, this.
Sorry.
Mute every.
Okay. So, how are we able to quickly assess the patients who are coming in that are high risk, and assisting patients when they're in crisis, and strengthening preventive efforts? There are lots of websites out there now where you can plug in, I have a patient with, Cantonese speaking, lives in this area, has food insecurity and needs XYZ, and then plug it in and pop there. It gives you 6 places, but they're not always open, those places. And there's often waiting lists. And so, at least it's a starting point, but it's not always, a solve. I worked with a company called Palantir, at my former job. Those of you may have heard of Palantir. They really were in the government space. and first, but they are now in the healthcare space as well. And we worked on a tool to identify high-risk patients like the minute they hit the ED. So these might be patients who were uninsured or underinsured, maybe didn't have stable housing, had cognitive and mobility impairments. And, we created this tool so that right away, managers could see these patients were here, make sure their teams were addressing the needs as quickly as possible. There was a lot of concern about using a tool like this. What are the ethical considerations of flagging a patient? Is there bias? Is this tool really, going to flag patients unnecessarily that really maybe don't need as much as we think they do? And there was also concern about like, okay, you're going to identify this, but now what? What am I going to do with this tool, right? We kind of came up with pathways of different things you could do to help these patients. I think there's also a concern too that the quicker you are able to triage and assess these patients, there's always going to be another patient behind that one. And so staff burnout is a real thing. And they really feel like you're just replacing, work we were doing with AI tools just to give us more, we're going to get more work. We're going to just keep getting more patients. It's never ending. So I think that there is some hesitation and some concern, and getting buy-in from healthcare workers to utilize some of these tools. Again, you should always be using your own independent assessment and judgment. These should be a supplement. They should not replace. I think we can all agree on that. Some key ethical principles to consider when talking about AI in healthcare is like, again, over reliance. Do we stop using our clinical judgment and we're letting it think for us, right? I think we can all relate to that there's that you're really scared of just stop thinking for yourself and you're just following what a computer's telling you, right? And Dr. Reamer certainly touched upon privacy and confidentiality, and concerns about security breaches. Unauthorized third-party access is certainly a big thing in healthcare. Insurance companies, having access to this information, cyber attacks as well. And of course, we have to ensure that these AI tools comply with regulations like HIPAA, and that all the data is properly encrypted. So that's really important in our field. And I think, as was mentioned earlier, as we revamp policies and guidelines, all of this it has to be, in your revised policies. What are the biases, the algorithmic biases and fairness? There certainly are biases related to race, gender, socioeconomic status, that can lead to discriminatory outcomes and misdiagnosis for marginalized populations. And, we certainly should be advocating for inclusive data practices and like regularly auditing these systems for any bias. And that all feels like overwhelming. And I think people are very scared of that, and rightfully so. And then human oversight and accountability. Of course, we just can say this over and over again. It's not a replacement for your professional judgment or any kind of human empathy. It should never replace that. It can't really. And then ultimately, responsibility for client care decisions has to remain with the humanistic part of the social work side of what we do. And providing essential therapeutic relationship grounded in empathy and trust. You can't substitute for that, right? That discussion at the bedside, that human interaction, we can't lose sight of that. So these should only be tools to help us, not replace that. I am going to stop around and not do this case study because I want to leave time for questions and such. But I often end my presentations, especially to social workers, with a quote here that I took. It's again from Social Work in Healthcare, a little outdated, but I think it holds true. We work in very chaotic environments with a lot of pressures. And I think it takes a special kind of person to work in a healthcare setting and really balance all of that. And you have to be flexible and open and have that team-oriented approach and certainly customer-focused. And so I think that this quote just kind of sums up a lot of what we do, and the type of person practicing, in this field. And how you balance all of the clinical and regulatory things with serving a patient and advocating and empowering patients. And it's such an important profession that often doesn't get the recognition it deserves. So I just want to also say kudos to all of you that are in this profession. And it can be really rewarding. And I'm glad that I had the opportunity to be here today. So I am going to stop sharing. And
Thank you. It's such an interesting, I mean, you raised such interesting issues. Really appreciated your comments. First about some general ethical issues that happen, but then also just in terms of AI and the impact that it has on healthcare. So fortunately, I think I still have a little bit time for discussion. And I think a couple people might have said a few things in chat. Who would like to begin with the question, comment?
I'll go ahead and read what's in the chat, Elaine.
Okay, sure. Thanks, Jeff.
No problem. So Dr. Muid said, please speak to AI racism. And I believe that both of our speakers can respond to it. And then just as a follow-up, so Dr. Muid said, please speak to AI racism. Dr. Francis also commented, bias is baked in. So Dr. Reamer, Dr. Tenenbaum, what are your thoughts?
Go right ahead if you'd like.
I was just going to say, I think building these tools and the people building those tools, right, have biases. And certainly, I experienced that when we were trying to work on this tool to identify high-risk populations early on. And, there were keywords we were looking for in charts just to like flag these patients. And you really had to keep your own biases in check and not, make assumptions just because a patient was labeled as something that they should be, put in this box or this category, and make sure that the tools you were developing didn't reflect that. So, you can't totally eliminate it. There are, but maybe Dr. Reamer has more experience, with the ins and outs of it, and certainly from a legal perspective, but it's definitely a concern and it's there.
No question about it. And I'm not someone who says that every AI tool is replete with evidence of algorithmic bias, racism, whatever terminology you care to use. I do think there are instances where some of the AI tools that we have explored, those of us doing research in this arena, where we are finding evidence of algorithmic bias, racism, and so forth. I will pull up a resource that you might find helpful. I'll do this very quickly. This is a piece that Rutgers has put out there on AI algorithms used in healthcare that can perpetuate bias. I'll make the screen just a little bit bigger so you can see it. And I won't explore this in great detail, but it says what I think some of you are thinking and feeling. Quote, the AI algorithms increasingly used to treat and diagnose patients can have biases and blind spots that could impede healthcare for Black and Latinx patients, according to research co-authored by Rutgers.
You write exactly what you see and not what
I'm sorry, what were you saying? Somebody was saying something.
Somebody accidentally
All right.
went off
That's
mute.
okay. Well, that's why. This is how you find out what people are having for dinner and who's picking up the kids and who's going to shovel the snow and all of that. That's why we got to mute. Okay. But anyway, so this is a study that was recently conducted about the evidence that exists that AI can have these untoward impacts. I'll put it in the chat for anybody who wants it. So basically what I can say is, yep, it's a thing. And those of us who are doing research in this arena are doing what we can to identify it and address it as best we can.
Thank you. Dr. Kolb wrote in the pit wrote in the chat that the show The Pit received awards in AARP's Movies for Adults program yesterday.
Mm-hmm. And I also put a link in the chat for those of you who didn't see it. In today's New York Times, there is a commentary by Frank Bruni about The Pit, not just about the show, but about what it represents in our culture right now. And I think it's particularly relevant to social work. I mean, my wife and I are sort of groupies when it comes to The Pit. We think it's really remarkable. And I commend to you Frank Bruni's piece today with regard to its implications for us as social workers.
Yes, and they do a good job of portraying social workers in an ED and what they do, also nurse case managers. So it's nice to see that they do touch upon that.
They got good consultation. They clearly got very good consultation. Yeah.
Thank you.
Other questions, comments, different points of view about the role of AI in social work, behavioral health?
Yeah, I had a question, and in fact, was brought up in terms of race, and is there what about an algorithm? It's how concerned are we about kind of race or something that might be racist? I've thought about this in terms of women's issues, especially because I felt at one point, especially in the early days, I think this is much improved, where the algorithms used to seem to be mostly written by kind of young white men,
Mm-hmm.
and so I'm very involved and interested in women's issues. So this is a concern that I have, and I don't know, are two experts on AI. I mean, what you found or what you think of, about this issue.
Alicia, do you want to
I
take that?
would definitely say my experience, it's limited. There are less women in the field than men. I'm not sure that it's all white men, certainly in tech as well, and some of the coding and, that piece of it. But I definitely think, there women in general are less represented right now in that area. But, there's bias everywhere for sure.
So, ditto, I share the concern. And I don't have any hard data on this, but I would say, yep, it's a lot of the coding for AI is being done by males who are white, kind of like me. And I do think that's a concern, and we need to be sensitive to that. And bringing this close to what social workers do. So I mentioned in my comments that at this very moment, there is a prominent child welfare organization in Pennsylvania, Allegheny County, that has been using AI. So I've pulled this up on the screen. I hope you can see it. So you can give me a thumbs up if this thing is up there. The PBS there, upper left. Thank you. So the headline here is AP Associated Press report. DOJ, Department of Justice, examining AI screening tool used by, oops, let me see if I can get rid of that. I don't know if that, yeah, I think I can. By Pennsylvania Child Welfare Agency. And let me make this a little bit bigger so you can see it. But look at the first paragraph. The Justice Department has been scrutinizing a controversial artificial intelligence tool used by a Pittsburgh area child protective services agency following concerns that it could result in discrimination against families with disabilities. So much of the controversy around this tool to assess family risk, and it's called the Allegheny Family Screening Tool, Allegheny County, Pittsburgh area. But notice the explicit reference to discrimination. Well, this particular piece focuses on possible discrimination against families with disabilities. And I would say we have to be comparably, equally concerned about the possible discrimination associated with tools like this with regard to families that are low income, whose members are people of color. You've got kids who are struggling with some LGBTQ plus issues. So this is a major issue. It's a major issue. Algorithmic bias, possibly.
Thank you. So I used AI and I asked AI what would be a good question to ask two experts who specialize in ethics in AI. And AI came up with a pretty good question, I think. So I guess my question using AI is, who is accountable when AI makes a mistake?
So I will put on my so-called expert witness hat. I don't actually have one of those hats, but metaphorically, I'll put on the expert witness hat because I do so much of this kind of consultation with lawyers. And I will tell you that I think it's in flux. So as I mentioned, if you were here for my piece, there is now a growing list of litigation cases involving AI. those litigation cases allege negligence. Negligence under the law has four elements that the plaintiffs, the party bringing the suit, that they have to prove in court. And by a preponderance of the evidence. It's a lower standard than in criminal court cases, proof beyond a reasonable doubt. But in civil litigation now involving AI, the plaintiffs have to show evidence that the user, let's say it's a clinical social worker who has recommended an AI tool, they're using it for to generate clinical notes, that they had a duty to their client or in a hospital setting their patient. Element number one. Element number two, the evidence has to show that there was a so-called breach of duty or dereliction of duty. This stuff's been around since the late 1800s. And now what I am seeing is contentious debate, some of it's contentious debate, about whether social workers and other behavioral health practitioners who are using AI to provide, quote, therapeutic services, unquote, or using it to generate clinical notes, whether they're using this stuff in a way that violates what we call standards of care, breach of duty, negligence by omission or commission. And under the law, you have to show there was evidence of harm and what lawyers call proximate cause. Well, until like 2 years ago, I was not seeing this framework, which has been around for decades, used with regard to AI, but I'm now seeing it. And with regard to the question, who ultimately is found liable, this is, I think, an open question. In other words, I don't think we have enough litigation. I don't think we have enough track record to be able to assess the extent to which the clinicians who are recommending some of these tools, using some of these tools, whether they are going to be found liable, the extent to which the AI platforms themselves are going to be found liable. But I will tell you this, and I'm not going to take the time to pull it up. A year and a half ago, I couldn't do this. Today, this evening, I can. I can show you the names of lawyers in the New York metro area and in Chicago and in San Diego, and you name a metro area, I can show it to you. These are lawyers who have pivoted their practices and they are now litigating AI related cases. It has become a specialty in the law. And they are trotting out arguments that clinicians and sometimes the AI sponsors, the clinician supervisors, are liable when a client dies by suicide as a result of interacting with an AI tool. When a clinician doesn't proofread the AI generated note carefully and it is missing critically important clinical information, and then you have a bad outcome. This stuff is in flux. So stay tuned. I guess my short answer is the clinician could be found liable. The AI platform sponsor, creator can be found liable. The clinician supervisor can be found liable in theory if the supervisor didn't properly supervise the clinician about the use of AI tools to document clinical encounters. Lawyers have a phrase, a legal doctrine called respondeat superior, respondeat, then the word superior, pronounced superior, it's Latin. Bottom line, clinical supervisors, administrators, I think are going to be found liable for some of this stuff under this legal doctrine of respondeat superior, in addition to, in some cases, the clinicians themselves.
Wow. Thank you. Dr. Tenenbaum?
No, I mean, I don't think I can top that response. I don't have as much background experience with the legal aspects of it. I could say what I see is that, it's hard to get practitioners to buy into using some of these AI tools because they are concerned for all the reasons that Dr. Reamer just pointed out. Where is their liability start and end? How much lies with the institution, who purchases these AI tools and uses them and sets up practice guidelines around them. I think that's really important. We always say, oh, let's use these tools to work smarter, not harder, but I think there is a lot of concern there from practitioners about their liability and just, the use of these tools. And at the end of the day, it's their name on a chart, it's their signature, and they could be liable. And I think that's a real valid concern. And it doesn't surprise me that Dr. Reamer says there's like a whole field now of this in of lawyers that are using this as a platform.
Thank you. Before we end, I just wanted to make a quick note. Please join us again next week, next Monday at 5:30 for part 2 of this series. Oh, and Dr. Reamer. Oh, I see. New York Artificial Intelligence Lawyers. I believe you're on mute. Dr. Reamer, we
There
can't.
are multiple websites where those of you in the New York area, I'm in Rhode Island, so I don't care about, but you go back to the New York area, there are lawyers lining up for your business regarding AI litigation. And
Wow.
this is just one of many. Sorry about that. Yeah.
Why? No, thank you. Thank you so much. So yes, and thank you to our presenters. Elaine, I'm going to turn it over to you. Just again, please do join us next Monday at 5:30 for part 2 of this really, really important webinar, and so very timely. Elaine?
Yeah, well, thanks. Well, I just want to say, well, first, and thanks, thank you, Dr. Reamer and Elisa Tannenbaum. I mean, you were just wonderful and raised such important questions about ethics and about AI. It's just so so interesting, and so we're at the kind of almost the beginning stage, of this. It'll be interesting to see where it goes.
Absolutely.
So please join us next week. There was so much we wanted to talk about. I mean, we could have done like a whole semester of it, but of course we were limited because as much as Sonia likes to put on our programs, I don't think you wanted to put on something every single week of a whole semester. Anyway, we are going to be having 2 programs related to AI and ethics, and next week we're going to have 2 speakers. We're having Dr. Berlinger from the Hastings Center is going to be speaking, and Dr. Levine, who's here with us tonight, is from NASW and from Truro, is going to be speaking to us. So please join us next week also. If you have any other questions, comments, please feel free to email me. My email is very simple: congress@fordham.edu. And look forward to working more with you as we explore this issue. Thank you.